Hello and welcome to the continued amenorrhea section of your learning. I still have my yellow amenorrhea nails, new bracelet, new topic. We're talking about polycystic ovarian syndrome today. That is the commonest endocrinopathy in women and therefore one of the commonest, if not the commonest cause of amenorrhea and oligomenorrhea, especially in our South African population. Today's little broadcast is brought to you by my new wand, because I don't know where I put my other sparkly wand. So this is a paintbrush that has been re-engineered and brought to you by the Easter Bunny and coronavirus. It is the long Easter weekend. We're all frantically busy working to make you online content and we're all in lockdown. So die coronavirus, die, and Easter Bunny, make some space for us. Okay, so what are the main presenting complaints of polycystic ovarian syndrome? So let's have a look. Main complaints, as I said, oligo or amenorrhea is one, and infertility, difficulty falling pregnant or difficulty sustaining pregnancy. Those are the two commonest routes in, but probably the oligoamenorrhea is the commonest one. Now this one usually has quite a specific pattern of anovulatory bleeding. What is that? That is, so the underlying pathophysiology is that a woman is not getting her monthly LH surge, and so she doesn't ovulate regularly every month. But the endometrium continues to be laid down in between. So a woman might ovulate in January and then not have any periods until, let's say, April. But the endometrium has been laid down throughout that period because the estrogen is still working. So when she does eventually ovulate randomly, and if she doesn't conceive and she has her period, that's 3-4 months worth of menstrual blood that is going to come out. So the periods are usually very heavy when they do occur. Okay, or it could be amenorrhea for a much longer time. So a woman sitting in front of you with amenorrhea, definitely the first thing to think about is polycystic ovarian syndrome. Now, these are what patients are going to come to you with, but let us not forget that there are longer term issues. Okay, this is a syndrome that's got a whole lot of things attached to it. So it is attached to metabolic syndrome as well that can potentially cause long-term issues. And if we don't protect the endometrium, then it can become cancerous after years and years. What is the mechanism for that? Well, if the endometrium gets laid down and laid down and laid down unchecked and it doesn't shed regularly, then after decades, that endometrium can start just randomly proliferating on its own, and it can cause hyperplasia and endometrial cancer. So we have to control the endometrium. I just need to do something that my phone is talking. Okay, there we go. Right, so what are the particular things that you would look for on history? I mean, obviously you're going to do the full gynae history, but the particular things to note are the nature of the cycle. So like I said, you are looking to determine whether it is an anovulatory pattern, which would make it maybe a bit more likely to be PCOS. So what are the periods like? What is the flow like? You want to ask about any hirsutism, so we're talking about virilizing features now. You want to ask whether she's on contraception, because we know that women who have bleeding abnormalities who are on contraception, the most likely cause of that abnormality is contraception. So that's an important question. You can ask her if she's struggling with her weight, because women with PCOS will often complain of that. You want to know whether anyone else in her first degree female relatives has got the syndrome. This is a genetic disorder. It clusters in families. It clusters particularly in people of Cape Malay descent. So it will add evidence to your argument if there are other people. And then something to think about is if these women have voice changes, or sometimes they have an enlarged Adam's apple. PCOS is not the only thing that can cause virilization. So an androgen secreting tumor in the adrenals can also cause virilization, and those can be malignant. So if somebody's having voice changes, their voice is much deeper, or they're having obvious and rapid male pattern hair loss, that is a red flag for something that is definitely not PCOS. It needs to be referred urgently. Okay, let's go to what kind of things could you expect on examination. So examination, you are looking for hirsutism, as we've said. Acne, that's actually another thing that you can ask on history, if there's new or worsening acne. You can look for striae on the abdomen, so evidence of significant weight gain. The pelvic exam is going to be normal. Yes, the ovaries are enlarged in PCOS, but not to such an extent that you're going to be able to palpate them. So the examination is going to be normal if it's PCOS. You definitely need to check the BMI, and you definitely need to check the BP, because remember, the metabolic syndrome is an issue. So here are some images. That is hirsutism. So it's commonly on the face, but it can also be on the abdomen, on the back. And this is acne. You can see she's also got a bit of hirsutism happening there as well. Okay, so now we're going to move on to the Rotterdam Criteria. These are criteria that help us make the diagnosis of PCOS. So Rotterdam Criteria include oligomenorrhea, virilizing features, I'm just going to move these over a bit, virilizing features that are either clinical, so you can see them, or biochemical. Oops, let me just move back a bit. So oligomenorrhea, virilizing features that are either clinical or biochemical. And the third one is PCO on scan. So what investigations are you going to need to do to have a look and see what's happening? So you are obviously going to do your, let me just move back so you can see, and I need to move the light as well. Okay, so obviously you are going to do a scan, and you are looking at the number of follicles. The exact definition is more than 12 follicles in the ovary, and the volume of the ovary is increased, but like I said, not big enough for you to feel it with your hands. And then if you are looking for biochemical, where's my wand? Biochemical evidence of virilization. These are the investigations that you need to do. So it'll be, there's a whole batch, but important ones are testosterone, sex hormone binding globulin, and LH and FSH. Your LH will be higher than FSH, which is a reverse in the ratio. Testosterone is higher, and therefore sex hormone binding globulin is lower, because sex hormone binding globulin's job is to mop up free androgens. So if there's more than normal testosterone floating around, it's going to bind to SHBG, so the free available SHBG is going to go down. Okay, and then let's not forget in investigations our full metabolic screen. These patients often have insulin resistance before they get full-blown diabetes, so they need to have a fasting sample for all of these. So when we do PCOS bloods, we just do all of these together as a fasting sample. Okay, so I'm going to sign off there temporarily, and when we come back, we are going to talk about the management.